slow. And then breathlessness has also come up around the same time.
If we
Okay.
think about the breathlessness, then or breathlessness or chest pain, it is relieved when the child is in sitting position and increased when child is lying down. So that points out towards cardiac cause.
So why does that happen in anybody? Any person who feels more breathless in lying down and is relieved in sitting, what is the logic behind that?
There is increased venous return from the peripheries uh, towards the lung, towards the right heart and the lung. Uh, this is classical of orthopnea. The person lies down, there's increased venous return that causes congestion in the lungs, and that increases the breathlessness.
Okay, anything else? Any mechanical issues? What happens to the diaphragm? What happens to the abdominal viscera?
The diaphragm and the abdominal viscera also get push up the diaphragm. So again, the chest is compressed.
So what you said is right, provided you have a cardiac pathology. But if you don't have a cardiac pathology and if you simply have a kind of a distension because of fluid accumulation, then also the same thing will happen because of mechanical pressure, that the patient will feel worse in the supine position and little better in the sitting position. So effectively, most breathless people will feel better in the propped up position. So one is, this is something to learn, that most breathless people will feel better in the propped up. Whether it can be traced backwards to a particular etiology is 50-50. Okay, fine. So now why do you think he has become breathless? So one you said is cardiac. Now, if this breathlessness is cardiac, do you think we change our analysis? Do you think this is not renal edema but cardiac failure edema? What do you think?
In the renal edema, dual effusion can also occur and can also lead
Agreed,
to.
agreed, agreed. So you are saying that breathlessness is possibly due to pleural effusion, due to renal edema, right? I agree to that. I am asking you the other way around, because we brought up that he's feeling better in sitting. So is this cardiac? So now I'm asking you, can this be cardiac failure and no renal? The first edema was due to cardiac. Now breathlessness is due to cardiac. I'm asking you, is that possible?
I think it might be possible because, as sir mentioned, the edema has progressed over 6 days and not like the time constraint is a bit longer.
So think of a child who goes in cardiac failure. What will be the sequence of events? What will happen first? Meaning he'll become breathless first, or he'll get pedal edema first?
Edema
Breathless first, no? Hmm? He has to first get breathless, then the failure has to progress, then he will develop edema. Secondly, that edema is slowly developing, so it will not start around the eyes, and so on and so forth. So this story, if it has really started with that edema around the eyes and all that, definitely this is not, the whole thing is not cardiac failure, right? That is ruled out. Okay.
Does cardiac problems come up with edema? Have you seen a child of cardiac disease presenting with edema? Then why are we considering cardiac problems in the differential diagnosis of edema at all? You've seen cardiac problems with breathlessness. When did you last see, even within a year or two of your experience, when did they come with edema feet? But adults do it. So why adults can come to the physicians with edema feet and not much breathlessness? Whereas the pediatric patients come with breathlessness, edema may be found by a physician or even may not be. What is the difference?
That is because in children, that is in kids, the primary compensatory response of the body is to increase the heart rate, and that is why edema may not be that significant. But in adults, the primary compensatory response may not be increasing heart rate, but to try and increase the contractility of the heart.
All right. The correct cause is edema is a manifestation of a congestive cardiac failure, which is a right-sided failure. And in children, majority of the times, it being acute or even when it's prolonged, it is a left-sided failure primarily, which may spill over the right side. And therefore, the presentation is rarely edema, presentation is breathlessness. This presentation has come up together with edema. So breathlessness, yes, may be cardiac, but the primary renal. So can renal problem like a nephrotic syndrome as a prototype, let's call it nephritis. Then would that cause a cardiac problem almost simultaneously? Both are 6 days duration, right? So both have come up almost together. So why should a renal disease present with cardiac problem together?
So can a renal disease cause something that can affect the heart also? One you said was pleural effusion and breathlessness. Can the renal disease do something to the heart indirectly? Can they develop hypertension? Okay. So then how will that affect the heart?
It will require heart to do more work.
So sudden significant hypertension can also cause cardiac failure and can cause breathlessness. So we are just thinking of the various possibilities. Now, uh, the going to the first thing, just teaching that in that first two lines, when you take the history, you have to ask them, was each day the edema was worse than the previous day, means in bigger in intensity, more. If that was gradually happening, so more puffiness, then first day there was no abdominal distension, no pedal edema, but second or third day pedal came up, fourth day abdominal came up. If that kind of a story can be built up, then it is almost sure that it is nephrotic syndrome and nothing else, right?
Can it be dengue fever? There's edema, the child is breathless. Will dengue fever have edema? Will they have collection of fluid in the third space? Yes, because there is leak there. They can have puffiness and they will become breathless. And it's something which needs to be addressed relatively urgent. Maybe, and it may take place on day 5, day 6. Can that happen?
So you've seen dengue fever, you've seen the edema in dengue fever. So how is the edema in dengue fever? Edema means what have you seen in dengue fever as a fluid collection?
Citus, pleural effusion.
In what phase of dengue do you
Leaky
see
phase.
pleural effusion? In the early phase, late
Leaky.
phase? Pardon me?
Leaky phase after 5 days of
That
4
means
to
in
5
the
days.
recovery phase you may see, because the fluid which was being given has not been reduced. There's a U-turn, isn't that so? Initially you give fluids, and later on you see restrict fluids. Also, there will be a history of, which suggests, I'm not talking only of that, there will be a history of what type of history? Can you suspect dengue on day 1 of fever or day 2 of fever? You can suspect, though you will not diagnose, abrupt onset of very high fever associated with headache, body ache, and backache. And the patient comes to you.
ఒక సెల్ ఫోన్ నేను జూమ్ లో ఉన్నా జూమ్ చెప్పు చెప్పు ఒక జూమ్ లో ఉన్నాను నేను
So you will not diagnose dengue, but if the child has been brought on dengue, you will say that we don't know what the cause of fever is, but we will always keep dengue in mind. This particular child didn't have any abrupt onset of fever, etc. The reason to mention this is often we talk of cardiac, hepatic, and renal edema, but we sometimes tend to forget a very relatively milder variety of edema in a child with dengue, which may be perhaps little more urgent than any of these things. Isn't that so? So we keep that also as one of the possibilities.
I think dengue is one cause of edema, but it never starts on day one. Here the patient has started with edema. Second is, it doesn't progress to have a generalized collection of fluid. Much before that, he is in cardiac, he is in circulatory failure and shock. So one would never see a generalized swelling with abdominal, pleural in dengue at all. Much before that, he would go into a shock and he would present with shock within next 12 or 24 hours, often 3-4 days down the line when the fever is almost disappearing. If you look at this child's fever and edema at the onset, then there is nothing else but a renal problem. But why fever? Most of the nephrotic syndromes don't start with fever. So there are many unusual features in this child. Age is unusual. Onset with fever is unusual. Okay. And then progress is slow in terms of edema accumulation. Okay. Rarely nephrotic would say, morning I started with edema, by evening it had disappeared. And the next day again the same. It would fill up in 12-24 hours. This is filling slowly. Other thing about breathlessness, but breathlessness has come up slowly also. He said that first he could even walk in spite of that. So the cardiac problem has come 2-3 days down the line and slowly coming up. So it's a slowly developing breathlessness. In dengue or in nephrotic syndrome, typically pleural effusion is not large enough to cause breathlessness. It's on examination there is some fluid. Similarly, the abdominal pain. And therefore, these many things tell us that this edema is neither liver, not primary cardiac, nor nutritional, nor capillary leak, etc. But it is renal, complicating in a short time with cardiac problem. Now the question is, what do you make out of that vomiting coming up? Somebody to talk on that vomiting?
Any thoughts on vomiting?
Due to raised BP.
Yeah, it can be due to raised BP. So first, see, we should have our thoughts clear. So vomiting since 6 days. So what does that tell you? So generally, when you see vomiting in any illness, in a gastro, what is the course of that vomiting? You get a GI infection, gastroenteritis, rotaviral. What is the course of that vomiting?
Maximum in the initial days and then subside.
How soon? Within 1 or 2 days. So this is vomiting going on for 6 days. Okay. Secondly, 1 to 2 vomits per day. So is it it's not even progressive. As in, do you think if I ask you, is it acute abdomen? Just looking at this vomiting, what is your answer? No.
No.
Do you think this is raised ICP? No. This vomiting is not even progressive, but it is constantly there. So, what is the anatomy? As in, where is the problem which is making this child vomit? You're right that high BP can make someone vomit. What? Where is the problem? Is it coming from the? Is there something wrong with the stomach? Something wrong with the intestines, or something outside?
Something outside.
Outside, what could it be? So we said it's not CNS. We said, can it be renal failure? There's reduced urine output. You said once a day urine. So has this child gone in renal failure and that's why this child is vomiting? So again, we need more details about that once a day urine, whether it is every day once a day, whether it is gradually going down, like yesterday was 3 times, day before was 5 times. What is happening? Because once a day is extreme oliguria, and we need to know for what period of time this is happening, right? But can this be renal failure?
The history of decreased oral intake also. Overall, we have it can be done.
Okay. So it's basically what I would think is we need more details. Just because somebody has decreased oral intake, you don't get into decreased urine output just by decreased oral intake. Decreased urine output has to have losses somewhere, either obvious or third space. No, if I don't eat for 24 hours, my urine output will not go down to once a day, right? So, and then also the question, why is the child not eating? Since when is the child not eating, right?
Would nephrotic syndrome cause diarrhea? Sorry. And the answer is yes. And why? Because there is an edema of the intestinal mucosas. So imagine same thing happening in stomach. It could cause vomiting. So one cause could be a nephrotic itself. Okay, diarrhea is obviously known cause, but not severe. So whether this is just representing that severe intraluminal edema as well. That's number one. Second is this is not a renal failure because what does the word failure mean? The organ has failed in its routine function. And how to recognize a failure from dysfunction? A failure affects other systems, and most commonly the first symptom is a CNS, and he becomes lethargic. Okay. Look at hepatic edema, hepatic encephalopathy, renal encephalopathy. Look at circulatory failure, shock, again encephalopathy. So failure is associated with encephalopathy as a secondary to the dysfunction. So this is not a renal failure. So again, decreased urinary output is simply a low intravascular volume and therefore an impaired renal perfusion. So that much we know. So I think vomiting is significant in this child because it has lasted for 6 days, but it is not severe. It's naturally manageable. Okay. And that's to me maybe just a gastropathy. Whereas to me, a simple hypertension may not cause vomiting. But when failure starts coming up, cardiac failure maybe, or whatever, the complications. Okay. It's not renal failure with metabolic complication. The cause of vomiting is not metabolic, not CNS. So I would say it is a local gastropathy. And we leave it at that. It does not add on to a great information.
I think two of you have joined us so late. So 4-year-old boy brought for 6 days of generalized edema, 6 days of breathlessness, gradually progressive, and a little bit of vomiting, right? We were discussing that. Okay. Comment on these past illnesses. What are your thought process? What is the first illness? What do you think is the first illness? Any thoughts here? What was that first illness? What does it look like? Bronchopneumonia. So henceforth, let's not use the word bronchopneumonia. It's a very vague word and it's actually not much in use now. This first illness is what? Fever, cough, cold for 3 days. Now, once you have fever, cough, cold, what is the first thing that strikes you? Multi-symptom or uni-symptom? Multi-symptom. Generalized or localized? Generalized. So you start thinking whether it's viral. Okay. The fever was high grade, which could well be with a viral in the beginning. Cough was productive with very small quantity of white mucoid sputum and associated with increased work of breathing. So what does that tell you? Which which conditions would have increased work of breathing? So if it was LRTI, how did it get better in 3 days? In 3 days, he was fine.
Just be a hyperreactive airway.
Very good. So it is mostly a hyperreactive airway disease. That's why increased work of breathing. And otherwise, the fever is a very trivial illness, a viral infection. So V is associated viral, right? What's the second one? Past history of pneumonia 1.5 years ago. So whenever you get such a history, you should cross-examine that history. So what is your stamp paper diagnosis that it was a pneumonia? It was really a pneumonia. Forget the discharge card, forget the sheets that they bring with you them. What question will you ask? Only one important question. Which makes it or throws out a pneumonia? High fever. So always ask whether there was high fever at that time. Believe me, there are hundreds and thousands and 10,000s of patients who masquerade as past history of pneumonia, but they never had fever in that episode. It was just a wheezing and cough with some opacity on the X-ray and which is labeled as pneumonia and treated as pneumonia. So many patients in this category, right? So always ask whether there was high fever.
What is against pneumonia in the statement that you have given me? Typical bacterial pneumonia starts with fever on day 1, a breathlessness on day 2, with a mild cough. And as the improvement occurs, breathlessness is first to disappear, fever the next, and the cough worsens. That's a typical progress of a pneumonia. Tell me, in this statement that you have made, something is against pneumonia. With whatever little information you have given, it's enough for me to say it cannot be pneumonia. Pick up something that cannot be pneumonia.
Discharged in 3 days.
Absolutely. Discharge in 3 days. Which pneumonia we are talking about? Who is breathless? And it's this, yeah. So this is
So
a
after
bronchoscopy.
needing oxygen, if it can be discharged in 3 days, that doesn't fit in with a pneumonia. Whereas a wheeze could need oxygen and get discharged the next day also, right? So just for the exams, never say that the deficit is 0.1%. Okay. So in exams, you say there's no deficit. Okay. Now, this calorie deficit is all along, like he's 4 year old. So ever since he was a baby, he's 50% calories. That's also important, whether it has the intake has gone down only now or it is all along, right? Because then your thought process is you're thinking of a malnourished host all the time. And then your whole many other possibilities can come.
22 grams of proteins, managing with 700 calories is difficult. Though I agree that it is easy to meet with protein requirement, calories is more difficult because calories means volume. Unless the child consumes volume, difficult. But this difference is too much. 22 is too good and 704 is relatively less.
In fact, that reminds us that we should recalculate. Are we going wrong somewhere? Right? Because this is a little skewed. Okay. Come now, give us your diagnosis on history and then we take it further.
The case of hyperreactive airway disease. So this time the child's breathlessness could be as a result of that, or it has to be explained only on the basis of edema. If you find it is difficult to explain it on the basis of edema, going by the chronology, you can take the help of this, provided there is significant cough. Because in hyperreactive airway, the breathlessness will always be later. Cough is a more prominent symptom, not breathlessness. So this particular child had significant cough along with the edema that he had and was breathless and quickly relieved later on. And because there is a past history of hyperreactivity of airway, you have to consider the other possibility. So here he didn't have significant cough in this particular case.
Summarizing the history, this is a 4-year, 11-month-old boy with complaints of fever, cough, and cold 15 days ago, followed by generalized swelling of the body since 6 days, associated with difficulty breathing, with reduced oral intake and reduced urine output in a birth and developmentally normal child, immunized to date, probably a case of nephrotic syndrome. So,
There are many, many points against a typical minimal lesion nephrotic syndrome. That's one point. And therefore, all that we would say is that one thing, nephrotic syndrome is also nephritis. So let's start talking it as nephritis, which is presenting as a generalized edema. And therefore, the point that I want to make is that this is not the usual minimal lesion nephrotic syndrome. So it has to be something different. But most of the nephrotic syndromes do not start with fever. So something unusual. Most of the nephrotic syndromes, even it's an immunological disorder, they don't have often the history of hyperreactive airway in the past. And therefore, many unusual features in this child, which makes us necessary to debate on what's the kind of pathology and etiology we are looking at. Nephrotic syndrome, yes, but must be something unusual nephrotic syndrome. The moment you say nephrotic syndrome, you start talking about a complicated nephrotic syndrome or a typical nephrotic syndrome. Okay. but they do not start with fever. So then, why not call it some different types of nephritis in this child, which is presenting as a nephrotic syndrome? After all, nephritis is a glomerular disease. Nephrotic syndrome is also glomerular disease. Both are inflammatory. But if you say it's a nephritis, then I would ask you, what is the possible etiology? When you say nephrotic syndrome, we believe it's minimal lesion or some other glomerulopathy. So considering fever as the onset, what can be the possibility of this etiological diagnosis in this nephritis is worth debating. Any thoughts on that? I'm sure I'm just making a point that this is not usual nephrotic syndrome. Okay.
The fever was in this illness or it was that 15-day back? In this illness, there was no
But you
fever.
said it started with fever.
15 days ago, there was fever.
But fever for 6 days, no?
No, no, no. This time is without fever. This time is just edema.
But edema and breathlessness has come together.
Yeah, means
Even
all.
that is
Yeah,
not.
correct. That is very unusual.
If there is fever,
No, there's no fever this episode.
uh,
There was some fever earlier, 15 days
so this
back.
fever had no episode.
No, this fever has no. This
I
episode
thought
has
you put fever as the thing.
no fever, cough and cold 15 days ago.
No, no, no. First line. No.
Swelling and
Okay,
breathlessness.
okay.
And
I thought it was fever also. Yeah, fine.
If we want to explain the edema or breathlessness on the basis of previous HRAD, then cough has to be a significant symptom. In the absence of cough, breathlessness, in a case of HRAD, is not like. In fact, cough is more prominent than breathlessness.
Even if we consider no fever, the onset of edema and breathlessness together is unusual. Breathlessness coming over slowly is also unusual. Now, what can bring edema of a renal etiology with hypertension and breathlessness almost together is really a glomerulonephritis. And typically, a post-streptococcal AGN can present together.
sir, I agree fully. So, but I thought for exam purpose, suppose they have to answer, they would rather call it nephrotic syndrome, but
typical.
atypical or complicated.
That's right.
They don't have history of hematuria clinically. Therefore, they might be fingered. Okay, on what basis are you calling? Right. On what basis are you calling it nephritis?
No,
To which,
see, let me tell you again, nephrotic syndrome is nephritis only.
sir, exam they may not be.
Yeah,
The examiner will not
correct.
accept. That's
But
the
no nephrotic syndrome come with breathlessness as a
Correct.
presentation.
Correct.
Even a complicated nephrotic syndrome will not come with breathlessness. This child has come with breathlessness. To me, therefore, this is some different etiology which we may have to just make a guesswork. Okay. For example, which other etiologies you know of nephritis which are not classically post-infective AGN or even post-infective viral, and to which you call of immunological, like an HUS, for example. Okay, HUS may not have obviously all symptoms of hemolysis, etc., but may come with only nephritis or any other kind of nephritis. So I would imagine that you're right, that if you say this is an atypical nephrotic syndrome rather than complicated. Complicated would mean nephrotic typical, which became complicated. Maybe secondary infection, maybe whatever. This looked like an atypical nephrotic. And to me, atypical nephrotic is something. For example, if this was a female child little older, I would say, is it an SLE doing it? That's what I mean by atypical etiology.
On presentation, the child had a heart rate of 94 per minute, a respiratory rate of 44 per minute. Saturation was 100% on room air. Peripheral pulses were poorly felt, and the BP was 80 to 58, which was around 5th percentile for the child. Extremities were cold till ankle and wrist. The child had no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. There was bilateral pitting pedal edema present till below the knee. Periorbital puffiness was noted. On and blood pressure is low, sir. On exam,
Peripheral pulses were poor.
anthropometrically, the child, the weight per age was 16 kgs, between -1 to 0 standard deviations, which is normal. The height per age is at 96 centimeters, which is -3 to -2 standard deviation. The child is stunted. Weight for height is normal. Head circumference is normal, and mid upper arm circumference is also normal.
How do you interpret this?
Interpret the height. 96 centimeters in a 6-year-old child is 4-year-old child. So 4-year-old child, how much would you expect?
Around 100 centimeters.
Yeah, about 100. Now 96 is less. Is it too less? Not much. So he's not a short stature. Therefore, chronic problem probably doesn't. For a 3.5-year-old child, how do you like the weight of 16 kg? Of course, in this particular child, you have to take into consideration the edema also. So we don't know out of this 16 kg, the real weight may be even 13 kilos or so. If it is 13 kilos for a 4-year-old child, it is definitely less. But if it was 16 kg for a 4-year, it was not too bad. And then -1. And here you have written height is -3 to -2. I thought 96 was little better for -3 to -2. Weight is, of course, on the lower side. There's no question about it. Partly because the existing edema that you have. And weight for height has become low here for the same reason. But not too bad. +1 is appearing better because of the presence of edema.
6 probably might fit in -1, -2 at the most. So we'll not call it stunted, right?
As a general rule, here of course it's getting complicated by edema, but as a general rule, whenever you get weight for height on the plus side, where do you get it typically? Weight for height is either okay or it is poor in majority of our cases. In which category of diseases do you get weight for height plus? Means weight is better but height is poor. So chronic disease, no. Why is it not a chronic disease? In chronic disease, what should be low? If height is low, should weight be okay or it should also be low?
Weight for age will be low, but weight for height may be
Maybe
appropriate.
normal, but it can't be better, no? So the point is, that's the point. Chronic disease. So by chronic disease, I mean chronic kidney disease, chronic liver disease. All of them will have weight and height both low. So weight for height is either low or okay. Okay. Endocrine diseases are the one where you will have height low, weight okay, not bad. And therefore weight for height is on the plus side. Okay. So when you have this combo of height low, weight good, and weight for height plus, keep in mind this combo is endocrine, not in this situation, but think it that way.
Can it be obesity, overweight?
In this case, difficult to comment because of the edema.
No, in general. The weight is more, the height is more, the weight is more than height. We saw here, weight is more, the height is less. You have one presentation. The weight is more, the height is more. Even the weight is quite a bit, but even the height is better. So in other words, obese and short stature and obese and proper stature, what is the difference in etiology? That's what Dr. Chokani mentioned just now.
Obese and short stature tends to be endocrinological
Yeah. And
disorders.
obese children are little taller than what we expect. They will not be very tall. So obese and short is endocrinal. Obese and tall is overnutrition.
Like in dehydration, you consider a weight drop by 5%, 10%, or 15%. You can almost go the same way when there is an accumulation. Now, this has got a massive collection. So maybe 10 to 15% of the weight recorded, you remove that much. So from 16, if you remove 2 kilos, it becomes 14, and 14 and 96 becomes reasonably fine, if at all a weight a little lower, but certainly not the height stunted, right?
On systemic examination,
One sec.
per abdomen, the abdomen appeared distended with the flanks full. Umbilicus is central, smiling umbilicus noted.
RR was 44 HR. Would you like to comment on that? Let's go back. RR 44, HR 94. Saturation 100%. Cardiac disease, respiratory disease, or just an edema? Just mechanical discomfort.
Mechanical discomfort.
Do you think mechanical discomfort would give rise to a breathing rate of 44 in a 4-year, 6-year-old child? I thought for this, HR is almost normal, mildly into. 44 was little too more for by any standard for mechanical. So without going further, I do feel that there has to be some respiratory component to that. And we have our hyperreactive airway disease, past history to that. So maybe concurrent with that, there could be wheezing. Maybe we may find it on examination. BP is of course low.
But if you're calling it respiratory disease, the SpO2 is 100. So if it is respiratory disease, where is it more likely to be? Airway, and which other respiratory disease can have a SpO2 of 100 and still the child is breathless? Pleural effusion also SpO2 will be 100. Okay. This pulse is weak. Is the child in cardiac failure? What do you all think?
The pulse is weak with BP on the lower side and extremities cold does suggest some amount of shock setting in.
Right. So then what is not fitting in? What is not fitting in? If you are saying all that is compensated shock, then
The
what?
heart rate
is not fitting in, right? Heart rate has to be much more. So I would have thought that the peripheral pulse is poor could be even because of edema. So you have to, means I'm saying there are so many factors that you have to think. Okay. Pulse is poor could be edema now if your BP accurate or no, that way. Why is the heart rate not high if it is cardiac failure?
RR and HR give you a lot of effects. And we often tend to overlook two things, weight and height, and we don't try to correlate each other, and RR and HR, and we take them relatively simple, but they give a lot of information.
on systemic examination per abdomen.
Child is not.
No, such child is in PICU. The abdomen was distended, flanks full, umbilicus was central, smiling umbilicus noted.